Welcome, curious minds, to another deep dive. Today we're going to unpack something truly fascinating. It seems like just a simple bulge, but believe it or not, it's actually the most common congenital defect in calves.
That's right.
And it's not just a minor thing. It holds a surprisingly complex and often pretty costly story within it.
Indeed. We are talking about bovine umbilical hernias, and we'll be exploring this, really widespread condition in calves, looking at everything from its subtle beginnings right through to potentially life-threatening complications. It really shows why it's far more than just a cosmetic issue.
Okay, you've given us a stack of sources, articles, some great research, our own notes, and our mission today is basically to pull out the most critical and sometimes overlooked insights for you.
Mm-hmm.
Think of this as your shortcut, really,
Yeah.
to understanding everything from the genetics behind these hernias all the way to cutting-edge surgical techniques,
Yes.
all without the information overload.
Yeah, the goal is that you walk away with a comprehensive grasp of why this seemingly minor issue can sometimes rapidly escalate into a major veterinary emergency. And that has real impacts, on animal welfare and, frankly, a producer's bottom line.
Absolutely. So let's start right at the beginning. What precisely is an umbilical hernia?
Okay, so imagine a weak spot or maybe an opening right at the umbilical scar, where the cord was attached. An umbilical hernia is when abdominal contents, things like, fat or parts of the intestine or even the abomasum, the calf's fourth stomach, push through that opening.
But the skin stays intact on the outside.
Exactly, the skin stays intact. So you just see this bulge where it shouldn't be.
And it's not just common. You said it's astonishingly common.
It really is. It holds the title for the most frequent congenital defect in calves. We're talking prevalence rates in some breeds as high as 4%, maybe even up to 15%.
15%, wow.
Yeah, particularly in breeds like Holstein Friesians. That's a significant number of calves. It's a major economic challenge, a welfare challenge, and often it's kind of overlooked until it becomes a crisis.
Right. And the way they present can be quite different, can't they?
Oh, completely. It can range wildly. You might have a tiny, soft, reducible, meaning you can push it back in non-painful swelling in a calf that's otherwise perfectly normal. That kind of might even resolve on its own.
Okay.
But on the other end of the spectrum, you could be looking at a really severely ill calf. Systemic signs like fever, not eating, poor growth, especially when that hernia gets complicated.
And this is where the stakes get incredibly high, isn't it?
Absolutely. Early and accurate diagnosis is just critical to prevent those severe complications.
You're talking about things like incarceration.
Right, incarceration. That's where the abdominal contents get trapped inside the hernia sac. They just can't be pushed back in.
Okay.
And even worse is strangulation. That means the blood supply to that trapped tissue gets cut off.
Oh, that sounds bad.
It is. Both can lead to tissue necrosis, basically the tissue dying off. Then you can get widespread infection, peritonitis, and of course, significant economic losses for producers. It's a stark reminder that a seemingly simple defect can truly escalate into a major veterinary emergency, and sometimes very quickly.
So why do they happen? That's the big question, isn't it?
Yeah.
Let's dive into that next, because it sounds like it's a mix of things.
It really is. It's multifactorial. First up, let's talk about the genetic blueprint.
Okay.
Studies clearly show there's a strong genetic predisposition. We're talking about complex inheritance patterns, maybe dominant, maybe recessive, possibly even influenced by what's called a polygenic threshold.
Meaning multiple genes are involved.
Exactly. Multiple genes playing a role.
And you mentioned certain breeds.
That's right. Breeds like the Holstein Friesian definitely show a higher reported incidence. But it's not just cattle. Quarter course fillies, for instance, and pigs are also known for having congenital hernias sometimes. And then there are birthing factors, too. Things like multiple births twins, or a premature birth. These can elevate the risk.
How so?
Well, it often comes down to potential developmental issues or maybe just underdeveloped abdominal muscles. Those muscles are crucial for that umbilical ring to close up properly right after birth.
So what does this all mean for, say, a producer listening or someone working in animal health, if a lot of these are inherited?
Well, it means genetic screening of breeding stock becomes really important, doesn't it? Particularly looking at sires and dams that have a history of producing affected calves.
Right.
It's not just a good idea. It could play a pivotal role in reducing how often this happens in future generations. It really shifts prevention upstream, from just treating cases to proactively improving the herd's genetics. That can have a massive long-term impact.
That makes a lot of sense. But it's not all genetics, is it? You mentioned acquired factors.
No, definitely not. Acquired factors play a substantial and often preventable role, even in calves that aren't necessarily genetically predisposed.
Like infection.
Exactly. Umbilical infections, often called navel ill or omphalitis, they're a really prevalent acquired cause. Just imagine bacteria like E. coli getting into the wet navel, maybe it didn't dry properly, and that prevents the normal closure.
Okay.
And these infections, they can spread locally, for instance, up the umbilical vein towards the liver. Or they can go systemic, leading to really severe issues like peritonitis, septic arthritis infection in the joints, or even meningitis.
Wow. And it's not just infections causing acquired hernias.
No, physical trauma can also contribute. Trauma to the umbilical cord during birth or shortly after.
Like how?
Well, things like maybe manually breaking the cord too close to the body wall or using excessive traction during a difficult birth, that can directly disrupt the tissues and stop that natural closure process.
Okay, that makes sense.
Now, here's where it gets really interesting, and it's a connection I think is often overlooked, the colostrum connection.
Colostrum. How does that link to a hernia?
Well, you see, a deficiency in passive transfer of immunity, FPT, failure of passive transfer, which usually happens because of poor colostrum management. That significantly increases a calf's susceptibility to all sorts of infections.
Including navel ill.
Including navel ill, and as we just said, navel infections are a direct pathway to acquired umbilical hernias, so you get this kind of domino effect. Poor colostrum leads to FPT, which makes calves prone to infection, which then directly increases their risk of acquired hernias.
Yeah.
It really means that preventing hernias is actually a direct, tangible, and cost-effective benefit of just having a really solid neonatal calf health program in place. It's almost like a hidden key, you know?
Wow, I wouldn't have immediately drawn that line from colostrum to a physical defect like a hernia.
Yeah.
It's really insightful. Okay, shifting gears slightly. What about demographics? Does age or sex play a role?
Yeah, age definitely does. Hernias are predominantly seen in young calves. They tend to peak between about 1 and 3 months of age, often right around 5 weeks old.
And after that?
You very rarely see new cases popping up in calves older than about 5 months. So there's definitely a critical developmental window there for monitoring.
And sex. Are males or females more prone?
You know, the data on sex predisposition is actually a bit conflicting across different studies. Some research points to males, some points to females, and frankly, some researchers have found no real difference at all.
So maybe not a strong factor on its own.
It suggests it might not be a universally strong independent risk factor, which really just emphasizes the need for vigilance for all young calves, regardless of their sex. Don't assume one is safer than the other.
Got it. Okay, let's look inside. What's actually happening with the anatomy and the potential complications?
Right. So normally, after birth, that umbilical opening goes through a natural process called cicatrization. It's basically scar tissue formation. Think of it as the body's way of mending itself and sealing off the abdominal wall. Pretty neat.
But in a hernia case, that fails.
Precisely. A hernia occurs when that crucial natural closure just doesn't happen properly. Maybe it's a developmental anomaly. Maybe those abdominal muscles are underdeveloped, like we mentioned. Or maybe it's secondary to an infection that just gummed up the works and prevented proper healing.
And what's actually inside that bulge, that hernial sac?
Well, it varies. Most commonly, it might just be adipose tissue fat or the omentum, which is a fatty membrane in the abdomen. We call that an epiloceal.
Oh.
But you can also find loops of the small intestine that's an enteroceal. And in larger, more serious cases, even parts of the abomacum, the calf's fourth stomach, that's an abomacocele. Sometimes you just find peritoneal fluid that's accumulated in there too.
Okay, let's unpack this dangerous progression you mentioned earlier. Even small ones can get bigger.
Yeah, even if they start small and seem okay, umbilical hernias definitely have the potential to gradually enlarge over time. They can turn from, a minor issue into more of a ticking time bomb.
And the really life-threatening part is that incarceration and strangulation.
Exactly. That's when things get serious. Incarceration is when the contents get trapped inside and you can't push them back. And then if the blood supply to that trapped tissue gets compromised, that's strangulation. That is a severe, urgent emergency. It can turn deadly really fast.
And you'd see signs. What should someone look for?
Oh, absolutely. If strangulation occurs, the clinical signs are usually pretty stark. Imagine you walk into the barn and a calf that seemed maybe okay before now has a hernia that's suddenly warm, swollen, feels really firm, and is intensely painful if you try to touch it.
Okay, pain is a big one.
Huge. And the calf itself will often show obvious signs of severe colic. Things like grinding its teeth, maybe grunting, arching its back, being really restless, or just profoundly depressed. These are all massive red flags screaming, "Emergency! Vet now!"
And the consequences. You mentioned tissue death.
Yes, tissue necrosis. That dead tissue is a breeding ground for infection. You can get peritonitis, which is a nasty infection of the abdominal lining, and systemic sepsis, where the infection just spreads throughout the calf's body.
Leading to infections elsewhere.
Potentially, yes. It could seed infections in distant sites like the joints, causing septic arthritis, or even reach the brain, leading to meningitis. It just really reiterates the urgency. A seemingly simple defect can escalate so rapidly. Educating owners about these warning signs is absolutely paramount. Recognizing them fast can make all the difference.
Definitely. So moving on to solving the mystery diagnosis. It starts with the vet's hands-on work, right?
Absolutely. It all begins with that clinical assessment, a thorough physical exam, including very careful palpation of the hernia itself.
What are they feeling for?
The vet's looking to determine its size, checking if it can be pushed back in its reducibility, and looking for any signs of pain, heat, or maybe discharge. Assessing the size of the hernia ring, that actual hole in the body wall, is also really critical for prognosis and deciding on treatment.
And systemic signs matter too.
Hugely. Any systemic signs like fever, the calf being off its feet, or those colic signs we talked about, they're all crucial indicators that things might be complicated.
Beyond just feeling it, you mentioned imaging.
Yes, diagnostic imaging gives us that crucial window inside. It's like giving the vet superpowers almost. Ultrasonography is incredibly valuable here. It's non-invasive, which is great.
And what can it show?
It lets us clearly visualize and identify what's actually in the hernia. Is it fluid? Omentum? Intestine? Abomasum? It helps assess the size of the body wall defect, too. And crucially, it can detect and assess the extent of infection, like if there's pus within the umbilical structures, confirming navel ill.
So it helps confirm infection.
Yes, and it even guides safe needle aspiration if we need a sample. That's much better than just sticking a needle in blind, which carries risks.
What about x-rays?
Radiography, x-rays, they have their uses in vet med generally, but for umbilical hernias themselves, their direct diagnostic value is pretty limited compared to ultrasound.
Okay, and lab tests.
Essential for getting specific answers. A complete blood count, a CBC with the white blood cell differentials that can reveal systemic inflammation or infection. You might see elevated white blood cell counts, neutrophilia, maybe elevated fibrinogen. These are all indicators that something serious is brewing inside.
And you mentioned sampling before. For culture.
Exactly. Bacterial culture and sensitivity testing is even more important for guiding treatment. Ideally, you get that sample via an ultrasound-guided aspiration, so it's sterile, from right within the hernia or infected structure.
Why is it so vital?
Because it identifies the specific bacteria causing the trouble, and, crucially, it tells you which antibiotics are likely to work against it. This is vital for targeted, effective treatment, no guesswork, and it also helps combat the bigger problem of antimicrobial resistance.
Good point. And are there other things that could look like a hernia?
Yeah, definitely need to consider differential diagnoses. Other conditions, like maybe an umbilical abscess, which is just a pocket of pus, or even sometimes a condition called woody tongue, or other subcutaneous swellings, they can mimic a hernia. So it underscores the need for that thorough diagnostic approach before jumping to conclusions.
Right. So once you have a diagnosis, what's the road to recovery? Treatment strategies.
Okay. First up, there's conservative management. This is often the watch and wait approach.
Who is that suitable for?
It's really only suitable for small hernias, typically less than, say, 1 to 3 centimeters, maybe about 3 fingers wide. And they need to be reducible, non-painful, and crucially not infected.
Okay.
Especially in younger calves, maybe under 2 months old, these small, simple ones might actually resolve spontaneously as the calf grows and strengthens.
Are there techniques used, like bandages?
Sometimes, yeah. Techniques might involve applying things like elastic bandages or clamps, trying to keep the abdominal contents reduced, basically holding everything in place while the body hopefully heals itself.
But there's a catch, isn't there?
There's a big catch. You need continuous, vigilant monitoring. Absolutely crucial. Any sign of complication, the hernia becoming painful, not being reducible anymore, or the calf showing systemic illness like a fever that means things have escalated and you need immediate intervention. It's a delicate balance, between maybe saving costs and ensuring animal welfare. You don't want to miss that critical window if things go south.
It makes sense. So for the ones that won't fix themselves, or the complicated ones, it's surgery.
For hernias that are unlikely to resolve, or definitely for those that present with complications, surgical repair herniorrhaphy is the definitive answer.
When is it indicated?
Generally for larger hernias, say over 6 centimeters or more than 3 fingers wide, or ones that are irreducible, persistent, or complicated by infection, incarceration, or that really dangerous strangulation.
And strangulation means immediate surgery.
Immediate emergency surgery. It's not just an option, it's required to try and save the calf's life. And while elective surgery might be preferred for calves over 2 months old, just because anesthesia can be a bit riskier in very young ones, any complication dictates intervention, regardless of the age.
You mentioned surgical precision earlier, especially with infections. Can you elaborate on that? What exactly happens in surgery when there's infection?
Yeah, that's a great question because infection really changes the game surgically. For infected cases, the gold standard is meticulous en bloc resection.
En bloc, what's that mean?
It means removing all the infected umbilical structures, the hernia sac itself, and any infected remnants of the umbilical vein or the urachus, which connects to the bladder as one single closed unit.
Why as one unit?
The goal is to prevent any contaminated material, any pus, from spilling into the clean abdominal cavity during the surgery. It's about containment. And depending on what's infected, there might be specific techniques. Like, if the umbilical vein is badly infected, a procedure called marsupialization might be needed, where the infected vein is kind of stitched open to the skin to allow it to keep draining. Or if the urachus is involved deep down, sometimes even a partial removal of the bladder wall is necessary. It's a very precise and thorough cleanup operation.
Wow, sounds intensive. And after the surgery, is care just as important?
Oh, absolutely. Postoperative care is just as critical as the surgery itself for a good outcome.
What does that involve?
It includes things like a slow reintroduction to feed and mandatory confinement, keeping the calf in a small, clean area for at least 3 to 4 weeks.
4 weeks. Why so long?
It's crucial because the body wall heals quite slowly, and let's be honest, calves are active. If you let them run around too soon, they can easily disrupt the repair. So that confinement is key. An abdominal bandage is often a good idea too for support and protection. It's truly the make or break period for recovery.
Okay. And are there other therapies used alongside surgery?
Definitely. Adjunctive therapies are absolutely integral. Antimicrobial therapy, antibiotics are usually given, sometimes prophylactically just to prevent infection after surgery or for longer courses if there was already infection present. And ideally, that choice is guided by the culture and sensitivity results we talked about.
Makes sense. What about pain?
Non-steroidal anti-inflammatory drugs, NSAIDs like meloxicam, are really valuable for managing pain and inflammation. But, and this is a crucial caution, prolonged use of NSAIDs carries a risk of causing abomasal ulcers in calves.
Wait.
So it requires a careful risk-benefit assessment by the vet. It's about alleviating pain effectively without causing another serious problem down the line.
And supportive care.
Vital, especially for calves that were sick or compromised before surgery, things like fluid therapy, maybe nutritional support. It really underscores that recovery is a holistic process. You have to address the whole animal, not just the surgical site.
Right. So looking at the long view now, prognosis and outcomes, what influences how well a calf does?
Several factors influence the prognosis. Hernia size is one smaller, generally means a better chance either for spontaneous resolution or surgical success.
And complications.
The presence of infection or complications, especially something like a strangulated hernia, means the prognosis becomes much more guarded, much more uncertain. And the calf's age at treatment also plays a role. Very young calves can be higher risk for anesthesia, for example.
Now, you mentioned something earlier that sounded like a bit of a paradox. High success rate for surgery, but also high complication rate.
Ah, yes. It does sound counterintuitive, doesn't it? So studies might show a really good prognosis for the primary goal, like overall umbilical remnant resection, having a, say, 99% positive outcome in one study for successfully closing the hole and removing the diseased tissue.
Okay, 99% sounds great.
It does, but then you see in that same study a notably high complication rate, maybe 73%.
Right, 99% success, 73% complications. How does that work? What are those complications?
Yeah, it needs unpacking. That 73% complication rate refers to things that happen after the main surgery is deemed successful. We're talking about issues like surgical site infections developing later, the hernia actually coming back, recurrence, persistent swelling, seroma formation, those pockets of fluid under the skin, or even complications just from the necessary lengthy confinement, like respiratory issues or digestive upset.
Ah, I see.
So managing these secondary issues is absolutely critical for getting a truly favorable outcome overall, because they directly influence the total recovery time, the need for more vet visits, additional costs, and ultimately the calf's long-term health and productivity. So while the surgeon might successfully close the hole, the journey to full recovery can still be quite challenging.
That makes so much more sense now. It really highlights that surgical success isn't just about patching the hole, it's the entire recovery journey. And thinking long-term, while our sources didn't give specific numbers on productivity after hernia repair.
The general principle in food animal medicine is that these interventions aim to restore the animal to its full productive potential, right? Whether that's for milk, meat, or reproduction. And the goal with hernia repair is certainly the same, even if the road can be bumpy sometimes.
Okay, so that leads us perfectly into prevention. How do we stop them before they even start? Herd health management seems key.
Absolutely. Prevention is where the biggest gains can often be made, and it starts, really, with breeding program considerations.
Back to genetics.
Back to genetics. Given that heritable component, genetic counseling and selective breeding are vital, it really means being careful about breeding animals, especially bulls, that have a known history of producing affected offspring. It's about shifting to that proactive genetic improvement strategy, trying to weed out the predisposition over time.
Makes sense. And then day-to-day management, especially with newborn calves.
Neonatal calf management practices are absolutely the cornerstone of prevention for the acquired types. Optimal umbilical cord care is paramount.
What does that look like?
That means disinfecting the navel with a 7% odidine tincture, ideally within 15 minutes of birth. That's kind of the gold standard. And maybe repeating that daily for a few days, especially if the calf is in a potentially dirty environment. The goal should really be to have less than 1% navel infections on your farm.
That's a clear target. And the environment itself.
Hygiene of the calving environment and the calf housing is also critically important. Clean, dry maternity pens are a must. Prompt removal of the calf from the calving area to a clean environment after birth. Regular cleaning of calf barns, ensuring proper drainage. These simple steps dramatically reduce the bacterial load the calf is exposed to, and therefore the risk of navel infection.
Okay, and this ties back to that colostrum point you made earlier, doesn't it?
Absolutely. If we connect this to the bigger picture, the 5 Qs of colostrum management are just non-negotiable for overall calf health, which includes preventing navel infections that can lead to hernias.
Remind us of those 5 Qs.
Right. So, remember, cows don't transfer immunity across the placenta like humans do. Calves are born basically with no immune system ready to go. Colostrum is their only source of those vital passive antibodies. It's their first shield. So the 5 Qs are
Okay.
quality. You want good quality colostrum, ideally at least 50 grams of IgG per liter. You can estimate this using a Brix refractometer aiming for 22% or higher.
Quality. Got it.
Quantity. Get enough in them. Typically 3 to 4 liters, which is about 10% of their body weight, within the first 4 to 6 hours, and then maybe another 2 liters within the next 12 hours.
Quantity. Check.
Timeliness or quickly. Get that first feeding in fast, ideally within 1 to 2 hours of birth. Why? Because the calf's gut can only absorb those large antibody molecules effectively for a short window, and that ability declines rapidly over the first 24 hours.
Quickly. Makes sense.
Cleanliness, or squeaky clean. This is huge. Ensure clean collection of colostrum from the cow. Use sanitized feeding equipment bottles, tubes. Avoid pooling colostrum from multiple cows if possible, as that can spread disease. And even consider pasteurization to reduce the bacterial load without damaging the antibodies too much.
Squeaky clean. Okay.
And finally, quantify. Don't just assume it worked, actually check. Blood test a sample of calves between 1 and 7 days old for their serum total proteins. This gives you a good assessment of whether that passive transfer of immunity was actually successful across the group.
Quality, quantity, quickly, squeaky clean, and quantify. The 5 Qs. It's incredible how something like colostrum management, which we think of for preventing scours or pneumonia, directly links back to preventing a physical defect like an acquired hernia.
It truly reinforces that preventing these hernias is often a direct, cost-effective outcome of just running a really comprehensive neonatal calf health program. It all connects: hygiene, colostrum, navel care. It's all part of the same puzzle.
Okay. Beyond the immediate neonatal period, are there broader things?
Yeah. General biosecurity and stress reduction also play a vital, if maybe slightly more indirect, role.
How so?
Well, good biosecurity protocols, things like isolating new animals, controlling who and what comes onto the farm, Thoroughly cleaning and disinfecting equipment and
Yeah.
facilities, they all help reduce the overall disease pressure on the calves.
And stress.
Reducing stress is always beneficial. Using low-stress handling techniques, protecting calves from extreme weather, providing adequate nutrition, all these things contribute to the calf's overall health and resilience. A less stressed calf with a stronger immune system is just less susceptible to all kinds of infections, including those naval infections that, as we've thoroughly discussed today, can directly lead to acquired hernias. It's about stacking the deck in the calf's favor from multiple angles.
That's a great way to put it, stacking the deck. Okay, let's try and summarize. What are the key takeaways from this deep dive?
Well, I think the first thing is that bovine umbilical hernias are genuinely complex. It's this interplay of genetic predisposition and these acquired factors, like infection. It's not just one thing.
Right. And diagnosing them properly isn't just a quick look either. It takes that thorough clinical assessment, often needs advanced imaging like ultrasound, and benefits from lab support like culture and sensitivity to really get the full picture and guide treatment.
Exactly. And treatment itself ranges, doesn't it, from that cautious watch and wait conservative management for the really small, simple cases.
All the way to precise, sometimes complex, surgical interventions for the larger or complicated ones, especially those emergencies like strangulation.
And remembering that paradox, even with good surgical technique, those post-operative complications are surprisingly common. So that comprehensive post-op care, the confinement, the monitoring, it isn't just an afterthought. It's absolutely paramount to getting a truly successful outcome in the end.
And prevention seems truly multifaceted. It relies on that strategic genetic selection to try and reduce the inherited risk.
Combined with meticulous neonatal hygiene, that gold standard naval care, and robust general herd health management practices, especially that critical colostrum management, they all have to work together.
It really shows how deeply interconnected everything is in calf health, doesn't it? How a seemingly simple condition like a hernia touches on genetics, infection control, surgical skill, even long-term farm economics.
It's a fascinating example of veterinary medicine in action, really, seeing all those pieces come together.
So that brings us to our final thought for you, the listener. Given what we've discussed, especially those significant complication rates in surgical cases, even when the main repair is successful, and those intricate links between early calf health practices like colostrum and preventing conditions like hernias, what might be the next frontier in veterinary medicine for calves?
That's a great question to ponder.
Could we be looking at, say, highly personalized genetic health plans right from birth, tailoring management based on an individual calf's risk profile? Or perhaps, dreaming bigger, are there entirely new non-invasive therapies on the horizon that could maybe eliminate the need for surgery altogether, especially for some of those challenging, complicated infected cases? What innovation would you want to see next in animal health?